Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. I'm your host, Dan Carter. I've got with me Dr. Caitlyn McCaulley.
Hello.
We're here in the old treatment room again. I was in the studio. Never doubt our dedication to the podcast and love our fans because
this is Hurricane Helene edition. So
if you hear a little background noise, we are currently filming in a hurricane, but this is when we film, so this is what we do. And I'm happy to be here, Caitlyn. We had a safe drive in this morning. I hope you did as well.
Yeah, I did.
So got a great topic today, especially going into fall. Mm-hmm. We're going to be talking about equine asthma.
Yeah.
A lot of people call this heaves. That's kind of the colloquial name for it, the one that most people talk about.
Yep.
And as always, we're going to break this down. We're going to get into different types. We're going to get into what causes it, how we figure it out, and what you do about it. So it's a pretty common pretty common airway condition, especially here in the southeast. I feel like we live in asthma land, as anybody that's ever come down here in the spring knows.
Yes.
If you don't have allergies, wait a minute.
You will get them, yeah.
So let's talk about it. Let's talk about equine asthma, Caitlyn.
So we kind of break this into two kind of categories. You've got your mild to moderate asthma cases and then your severe asthma. So mild to moderate, the other name that we call it is inflammatory airway disease. And then your severe, it becomes recurrent airway obstruction. There we go. Or heaves. And then you also have your other flavor that we get a lot in the south, especially the southeast, which is your summer pasture associated ROA. So it's very common. We see it a lot, especially in the fall time. Right now you don't think that it's dry outside, but typically in the fall we get very dry, we get very dusty, we get a lot of allergens swirling around, and then it sets our asthma kids off in a hurry.
Absolutely. One of the things I like to watch too is I keep bees. I love my honeybees.
You do? I didn't know that.
Yes, I have honeybees. And it's funny because you can always watch, like when people say that these fall allergens aren't out there, I can tell you my bees currently are covered in pollen. Yeah. They are, most of it's goldenrod this time of year, but a lot of pollen in the spring, and then there's this other mad dash to go get pollen in the fall. That's their protein source to get through the winter. So it's pretty cool. But I can tell you, with keeping bees, you'll realize just how much pollen equals allergy.
Yeah. I feel like in the spring we physically see it, right? Like we get your huge yellow, like all your cars turn yellow, everything is terrible. Yep. But in the fall, it's definitely, I get stuffy about it every afternoon out here working, so it's definitely a fall associated disease as well. Absolutely. But yeah, so basically, like I said, we break it into those two categories, mild to moderate or severe. And so with that, you've got kind of two different populations of horses. You've got younger, more athletic horses that typically have your mild to moderate disease. And then you've got your older, more chronically affected severe disease. So
time plays a big role in that.
Yeah.
As we develop this asthma. I think the longer it goes undiagnosed, the longer it goes untreated, and a lot of these will sit there subclinical, and they'll eventually progress from that inflammatory airway disease into the full-blown recurrent airway obstructive disease. Right.
And the disease process and how it works, that completely makes sense, because you start out with basically what it is. It's the immune system is reacting to the allergens or the pollens in the environment, and then it sets off an inflammatory reaction in the lungs and in the airway. And so the disease it's an inflammatory disease, but it has three components. So the first one is, like we said, inflammation, and then that drives. You have all these inflammatory mediators and mucus and all of these things that are going on in the airways, which makes that airway become what we call hyper-responsive. So it kind of freaks out and overreacts to something that shouldn't be as big of a stimulus as it is. And every episode they have, it becomes worse and worse and worse. So it just drives that progression.
And I'm sure all our listeners are are very surprised that something that could be a very small problem in the horse way overreacts and makes a big deal out of it.
Shocking.
I do feel like that's half the stuff we deal with in horses is not the actual problem, but their overreaction to it, which is basically what we have here is what should be, a pretty mild stimulus to the lungs turns into a really big deal.
Right.
We start to get a lot of mucus production in the lungs, get thickening of those bronchioles, and they can actually, you'll actually get consolidation of the lungs due to the amount of mucus that these bronchioles produce.
Right.
And that's going to decrease our gas exchange, right? We're not going to oxygenate like we should. We're not going to get rid of CO2.
Yeah.
So it can set off a whole host of problems, and not to mention the risk of our secondary infections. I mean, mucus in the lungs, as you know, from having a common cold can very easily turn into a secondary infection.
Yeah.
So.
Yeah. So, I mean, I always explain it to people, like, if a lot of people go through asthma attacks and have asthma and are dealing with that, and it's the same thing. It's like breathing through a straw. They get very frantic at times, just because they just can't get any oxygen. And so it's definitely something that we like to catch earlier rather than later, and then, help you guys to manage for sure. I guess the third component to the disease is what we call remodeling or scarring. So like Dan was saying, you get narrowing of the lumen of the bronchioles, and eventually it scars down, and we can't fix it at that point. So we can't reopen those airways. We can't fix the scar tissue once it's there, essentially. So
I think what you're getting at, Dr. Caitlyn, is the sooner we find this, the sooner we start managing it, because very similar to asthma in people, we're not fixing this.
No.
Catching it early, I think, is critical to prevent it from getting to that remodeling stage. And as anybody knows with allergies, especially people that have asthma secondary to these allergens, we don't really treat this. It's a management thing. We're going to get into that later.
Yep.
But I think early intervention is the key. So if we're going to talk about early intervention, really owners, trainers, barn managers, first line of defense. All right, what are they going to see that's going to say, hey, we need to get the vet out? What are the things they need to be looking for? What do they need to see when they're like, we need to get this looked at?
Yeah, I think very early on in the disease process, what you see is maybe just some mild, like intermittent coughing. It's not like they're, out there hacking up a lung or they're really struggling, but they cough every now and again, especially when you're starting to put them into work, or you are cleaning stalls, or you are blowing the aisles. Like, they cough a little bit and you say, oh, okay, that's weird. And then you maybe take them out to ride them, and they're doing okay and through their warm up, and they're doing okay through kind of their midline of work, and then you go and you get them at max work for where they're at in their training, and they start to decline. They can't hold kind of that level of performance like they used to, and so we see a decrease in performance, and then as they get worse, their performance will decline sooner on in their work. So I think those are the early signs, which I feel like, Dan, because you do a lot of sports medicine and you see those performance horses, you get to catch those a lot faster.
I think it is a lot easier because a lot of my barns have got 20, 30, 40 horses in it.
Yeah.
You've got that one horse that every time you blow the aisleway coughs, or
Yes.
you've got those one or two horses that every time they go to the ring they cough.
Yeah.
Nobody else is doing it. That tells us that something's going on. And you're right. Like in my population of horses, it's going to be that decrease in performance. One of the things I get having trouble maintaining the canter lead.
Yeah.
They kind of cough a little bit right when they warm up. Once they, the trainers will say, once they clear their throat, they're okay. And then I pay attention to what, is anybody else in the barn doing that? Because as we I saw a lot of this when we were in the drought situation. I mean, we didn't get rain for months here. Dust is blowing. I get a few coughing horses, but I wasn't concerned because the whole barn's coughing when it goes to the ring if they didn't have enough water on it.
Right.
We see this a lot in the spring where we get a lot of coughing horses, but again, the whole world's covered in pollen. I'm not as concerned then, but when I've got those one or two that just can't shake it, or it's just always there, that's when we want to start looking.
Yeah. And I think the other things that you start to see as the disease progresses is an increased respiratory rate just at rest. They're sitting in their stall and they're kind of huffing and puffing. They're struggling to breathe. That rate is up. Sometimes the effort will be up as well. So you'll see some flared nostrils.
Yep.
You'll see what we call abdominal press, which is where they're squeezing with their abdominal muscles to try and force air out of those teeny tiny little airways. And then as that becomes chronic, you get the heave line that people always talk about and look at, and so that's a line that kind of goes along the bottom of the abdomen, which is formed basically by they're working their abdominal muscles, so they're like giving themselves a six pack at that point, and so they're like bodybuilding, and so it's just the muscle that you're seeing that's increased in its like thickness and its strength, just because they're having to use it in a way that it's not really designed to be used.
And a lot of that's a result of that loss in elasticity we see in the lungs. So the lungs are elastic, right? They need to expand and contract. And these lungs are able to expand, but it's harder for them to contract because they've lost that elasticity and they're not able to push that air out. So now we got this big abdominal effort.
Yep.
We've hit the remodeling stage at that point in time. We've gone past where we want to be.
Yeah.
We want to. Our goal is to find it long before that and try to minimize really seeing that at all. Try to manage these horses in such a way that we don't get to that stage.
Right. Yeah, I think then we talk about kind of what they sound like when they're breathing, and they sound, we call it a wheeze, and so it sounds, I don't know how else to describe it other than it's
a wheeze.
It is. It's a wheeze. It sounds like, I think somebody said it sounds like a dove cooing, maybe, but I don't really think, it's more harsh than that, I think.
I think the best way to explain it is you will definitely know it when you hear it.
Yeah.
Think about the way I describe it is it sounds like you're breathing through a straw.
Yeah.
And that's, again, if you've ever I've seen some of these that get these really acute, severe flares. And I mean, we're out there flooding them with steroids. I mean, I've even had to grab the atropine before because they are literally breathing through a straw.
Yeah.
It's one of my least favorite things to see because you just feel so bad for them.
Yeah.
And it comes on acutely. They're panicky.
And you can't make the drugs work any faster than they do. You wish you could, but you just can't.
Luckily, I don't see a terrible many of those. I see more of the slow onsets.
Yeah.
But I have had those acute flares, and it's just the worst feeling. It's just terrible.
Yeah, it's not fun. We definitely, like Dan said, want to get to it before then. The other thing you'll see sometimes is just some nasal discharge, so some of that mucus production that's coming out of their nostrils. But yeah, early detection and prevention and management is the best. So, if you do have one that coughs every now and again, or you kind of see them struggling a little bit when they're working, like, think about it, pay attention.
Yep.
Yeah.
Take a look.
Yeah.
Because there's a lot of things we can do to slow this down, and we'll get into that. So,
yeah.
All right, so you've made the phone call. Phone call comes in, hey, my horse coughing, I'm seeing these clinical signs. We're going to take a look, right?
Yep.
Let's walk through the steps. We get out there, we got this horse. What's the first thing we're going to do?
So first, I look at the horse. I make sure they're not like in active respiratory distress. And then if they're kind of stable, then I'm going to have a conversation with the owner and the barn manager and say, I get a lot of information from them about when are these symptoms happening? Are they associated with anything like stall cleaning, aisle blowing or sweeping? Did you just mow a pasture next to them or mow the pasture that they are in?
Changes in hay,
yeah. What type of hay are you feeding? Are you feeding on a round bale? Are you feeding on the ground, just loose flakes? Are you feeding in a hay net? Like, all of these things kind of play in. And then just really kind of getting down to what environment is that horse in when they're having these symptoms, and when are they the worst and when are they better. So I get a lot of information from that.
Thorough history. Get that thorough history.
Yeah. Very, very thorough, very detailed. And that, I think, plays a huge role then later on when we talk about management. Like, I need to know the circumstances of these clinical signs. But then after that, I'm going to do my full physical exam, so head to tail. And I spend a lot of time listening.
I think the physical exam, oftentimes we have a lot of cool diagnostic testing we're going to talk about.
Yeah.
And this is true whether it's a lameness exam, a neuro evaluation, colics, basically everything we do. The power of that physical exam often gets forgotten.
Yeah.
Because this can look
huge.
like a lot of things, right? So looking around, like you can have some of these same symptoms if you're dealing with an anhydrosis.
Mm-hmm.
You know, if it's 100 degrees outside, we got these same symptoms. The difference is if it's happening 100 degrees versus, 70, a temperature.
Yeah.
Do we have a pneumonia? Because a pneumonia can look a lot like this too.
Oh, yeah.
So that physical exam gets us a lot of information. In fact, this is on my list when I go look at horses for poor performance. Often I'm called out on the sports medicine side, got a poor performance issue. People are thinking, it must be a lameness. Let's call Dan. And I get out there and it's like, well, I'm not really picking up on this. And I'm standing, I love to watch the horse before I look at it. It's like, wait a minute, our nostrils are flaring and we're just standing here at rest.
Yeah.
And then it's maybe, okay, maybe our issue isn't lameness per se. Maybe we can't breathe.
Yeah.
And then that's going to change also the questions I'm asking during my history and things I'm going to look at.
Yeah.
So.
Yeah. And then, like I said, with the physical exam, we do spend a lot of time listening to the trachea, to the lungs. But then one of my favorite things to do is the rebreathing exam. So,
Yes.
it is a neat little trick. It is very low tech.
Sometimes low tech
But
is
it
for the
works.
wind,
It works. We literally take a large volume bag, so usually a trash bag, and we put it over their nostrils, put it over their whole muzzle. We make sure that it's pretty snug around, and then we free it up from their nostrils and just let them breathe for like 30, 45 seconds. Basically what we're doing is using their physiology to drive up the CO2 concentration in their body and in their brain, and that's what triggers you to take a breath. It's not a like, there's always this joke about the blondes that have the headphones in telling them to breathe in and breathe out. It doesn't work like that. It's your CO2 concentration goes up and that's what triggers you to breathe. So we can't tell them to take a deep breath, so we have to force them to do it. But we take the bag off, we listen to them again, we listen to the trachea, we listen to both lungs, all the lung fields. And then we also watch how they recover. So do they recover quickly? Do they kind of struggle? What does their breathing look like after we force them to take a deep breath? But it really helps, especially in the early stages where you're trying to pick up on those low-grade asthma cases where they're a little bit wheezy, but you can't hear it on a normal exam.
Well, and that's one of the things I think's always been interesting about horses. A lot of times when you see us going to do these exams, we're looking for quiet. We're asking, can we turn the fans off, turn the radios off? Because a horse's lungs, you should not be able to hear.
No.
Like that's a very important thing to remember. Like if you can hear respiratory sounds,
That's abnormal.
that's abnormal.
Yeah.
And by using, like you said, using the CO2, I always like to say the lungs are not have nothing to do with oxygenation and everything to do with acid-base balance, but we won't nerd off into that subject.
It's a little too deep dive.
I will dive off. It's one of my favorite things to talk about is acid-base balance and how the lungs do it. So we're going to leave that alone before I go down a rabbit hole that we can't get it back out of. But
we'd have to like flash up the whole equation on the thing, and that would just take entirely too long.
I always say that is the one tattoo I will pay for my people that run anesthesia.
Yeah.
Is I will pay for the Henderson-Hasselbalch equation to be written on your arm.
Yeah.
I think it's one of my favorites. But again, we're getting in a rabbit hole. Get out of there. Get out of there. My nerd's coming out. I apologize.
Yeah.
But physical exam, listening, taking a temperature. And just because you have a fever, one of the things I tell people is you can have both. It can start as an asthma case, progress to that secondary respiratory infection.
Yep.
But at the same time, and they can have a fever from it, but at the same time, I've had several horses with these subclinical respiratory infections secondary to an asthma that don't have a fever, don't have a change in CBC, don't have a change in SAA, maybe a mild increase in fibrinogen. But when we get in later and we start talking about cytologies, there's evidence on that cytology of secondary respiratory infection.
Yeah.
So,
Yeah.
a lot of things we've got to determine here, because when we get into treatments, you'll really understand why it's important to know exactly what we're dealing with in this case.
Yeah.
So
then I'll often let clients actually listen to
That's cool.
when I do my exams, just because I want them to be able to hear how bad it is. Like, I want
Right.
them to be able to hear so they can understand, like, we need to stay on top of this, because when we get into the management aspect, a lot of it's on the clients and a lot of it's on the
Yes.
owners. So I want them to really understand, what it's going on, what it sounds like, and kind of what we're dealing with, so they can kind of understand the gravity of the situation. But like Dan was talking about with cytology, so the next thing that we do would be to do some sort of sampling from the airway itself. So there's 2 ways we can do that. The most common one that we do is endoscopically guided, there we go, transtracheal wash, which is where we stick the camera down into the airway. We introduce a little bit of fluid, and then we suck that fluid back up, and hoping to get some cells, some mucus, basically just sampling the environment of the airway.
Well, I think that's important too. When we're doing these transtracheal washes, the great thing is we're also looking at upper airway, because we've got 2 components of this airway, an upper and lower.
Yep.
And so one of the first things I do is scope that upper airway. Pick up, hey, because you can have some upper airway conditions as well. And also the 2 sort of work together. A lower airway can lead to an upper airway issue, and an upper can lead to a lower.
Correct.
And so really understanding everything that's going on, and not just like, oh, he's heavy, here's some meds. We may be missing things. And so we do a lot of the endoscopic guided transtracheal washes. It's very simple. The camera just goes up the nose. It sounds scary, goes down the trachea. They're mildly sedated. I've yet to have one really have an issue.
No. And it's a lot less invasive than the normal transtracheal wash, where we actually have to cut down through the trachea, and it's much less invasive, it's much easier, it's much faster.
Showing my age here, that's all we had when I started, so I did a lot of percutaneous transtracheal washes. When we got the catheters that allow us to do this endoscopic guided, I'm sure we've got one around here somewhere, but we got endoscopes, we got backup endoscopes, because I really don't want to go back doing it again.
It's messy and it's difficult and it's not fun. I don't like it doing that way. The other thing we can do is a bronchiolar, I'm not going to be able to say it.
Bronchial alveolar lavage.
There we go, thank you. BAL is the easy way to say it.
Also, we use an endoscope for that.
Yeah.
We just drive it right down into the lungs.
Yeah.
Same thing, fluid in, fluid out.
Yep.
We're trying to harvest cells. Before you freak out, the amount of fluid we're putting in is pretty minimal. Your horse is not going to drown.
No.
The lungs are actually pretty amazing in how much water they can absorb. What I always like to think about is, if you want to know how much water's in your lungs, remember a cold day. When you go outside in a cold day and you see your breath, that's water vapor coming out of your lungs. It's, sweating's number 1 as far as loss of water, and loss from the respiratory tract, insensible loss. That's number 2.
Yeah.
A lot of water, and the lungs are great at managing it. We're not going to make anything worse.
No.
Don't be terrified. It's going to be fine.
Yeah, it is a very small volume that they can handle very easily.
Yeah. So when do you like to do which? When do you pick a trach wash versus a BAL?
Really depends on, do I think I have more lower airway disease that's down in the deep parts of the lung? Like BAL is where you're down in your very tiny little airways that are in the lung, like what we call the parenchyma themselves. And your transtracheal wash is more of your kind of more of an upper airway diagnostic. Yeah.
Yeah, it's always, I get asked that a lot, when am I going to pick which? I'd probably say 90% of the time I'm starting with a transtracheal wash.
Yeah.
I feel like it gives me a bigger overview. I'm getting both lung lobes there. Because what's happening is the lungs are moving this material out, and it's going into the trachea, and it's going up the mucociliary elevator so you can get rid of it. This is the phlegm when you got a cold.
Yes.
That's coming out of your lungs, gets wicked up through there. Those cilia are pretty awesome.
Yeah.
They're clearing that stuff out. And it's more of I would say it's more of the shotgun. You're getting everything.
Yeah.
That BAL, we got to pick right or left when we get down there.
It's more targeted. Yeah.
So
yeah.
I'm typically starting with a trach wash.
Yeah.
So we got a sample. This is when, to me, it gets fun. Like I'm a cytology guy.
Yeah.
I love looking at these things just because again, it's low tech, right? We've got all these great tools out there. I mean, in today's age, we talk about PCRs. We got great culture techniques. We talk about all these fluorescent antibodies, ELISA. Look at all this cool testing. This thing,
Old school.
We're going to make some slides.
Yeah.
We're going to put them under a microscope.
And we're going to look at it.
Yeah. And a lot of information from here, right? Mm-hmm. You know, and the cool thing, too, is if we have a question, I read most of these myself. You know, used to we had to send these out to a pathologist, to a clinical pathologist, and we're talking 4 to 5 days. We've actually got a really cool machine here called an imagist. The cool thing about that is we can do that cytology, and if we're unsure, we can send it out to a clinical pathologist here in-house, and within 2 hours,
we have an answer.
I got an answer.
Yeah.
Y'all, that's quick. I'm not a computer guy, but I'm starting to embrace the old interweb because that's a whole lot better than putting it in the mail, sending it to the lab.
And then the slides break halfway there, and you're like, dang it.
Here, I'm going to send it out. We got a team of histopathologists all over the world.
Yeah.
Somebody's reading the slide. So if we can't tell what we're looking at, or if we've got questions,
we know people who can.
we know people that do.
Yeah.
Put it on the images 2 hours later.
Yeah.
I mean, that's the cool part. Like, you're here at the hospital. If you're like, hey, let me go read this, I'm going to give you an answer now. And one of my favorite things, we do a diff quick, lets us look at cell architecture, what cells we're dealing with. And another old school technique, the old gram stain. You know, because when I'm reading these cytologies, it's not the presence of bacteria that I'm looking for. It's the presence of bacteria inside of a cell, specifically that neutrophil.
Right.
Horses love to make neutrophils. That's their jam, right? And so I'm looking at these neutrophils, and I'm saying, all right, I may have bacteria in the slide. When I'm doing a trach wash, I may have bacteria on the slide.
It's not a sterile environment. So.
No, it's not sterile. That's one thing people forget. Lungs, the upper part of the lungs and the trachea, not sterile.
No.
We're sterile to protect our sample.
Right.
Not to protect
the
them.
airway, yeah.
So, looking for that intercellular bacteria.
Yeah,
That's
is the body
thing.
actively trying to clear that
Correct.
bacteria, or is it a commensal that normally lives there?
Right.
Yeah.
So a gram stain, old school, very valuable. The cool thing too is, you know, if we do think we have some kind of secondary respiratory infection, by looking at that cytology, we say, okay, we do have intercellular bacteria. Bacteria kind of grossly grouped into 2 categories. We got rods and cocci, but more importantly, we got gram positives and gram negatives.
Right.
This is always tough because, again, color, not my strong suit. So usually I got to get somebody to come in like, hey,
What color is
this? But it allows me to pick the correct antibiotic.
Right.
You know, while I'm waiting, because of culture and sensitivity, we're 3 to 5 days out. And we got a bunch of gram-negative rods. I'm probably reaching for that. That's when I'm starting to grab my gentamicins, gram-positive cocci. I'm looking at my NAC cells. So it's, again, old school, and a lot of times we forget. Old school can be good.
Yeah, it's not bad.
So
It's still very helpful.
Right.
But yeah, so once we kind of figure out what the cell population looks like, if there is secondary bacterial infection or not, there's these fun thing called Kirschman spirals that we can see sometimes.
Love those.
Yeah, it's literally, it's inspissated or dried little spirals of mucus that are just hanging out in there. So those are kind of fun to see sometimes.
They actually cast that lower airway. You get so much mucus in there. You get down this bronchial, and it's like you poured it's like a mold of the inside. It's
tiny little airway.
It's my comfort spot. I tell people, I see Kirschman spirals, I feel very happy.
You're like, got it.
This is a slam dunk.
Yeah.
All right, slam dunk. I love seeing those.
Yeah.
I mean,
So
bad
those
for
are
the
fun.
horse, but at the same time, we know what we have.
Yeah.
Based on what we're seeing, I think the next thing I always look at is, do we need to send this out for a culture and sensitivity as well? I don't think we can preach the importance of a culture and sensitivity when we're using an antibiotic therapy. Get it right.
Yeah.
You know, the gram stain will get us pretty close. But that culture and sensitivity, again, everything, and you're going to hear this repeated in this podcast, diagnostics make the difference.
Right.
Be diagnostically driven.
Yep.
Know what you're going after.
Don't guess.
Don't guess.
Don't try 3 different ones before you get to the right one. Like, antibiotic resistance it's huge. They talked about it a ton when I was in school and kind of scared us a little bit, which is fair. I mean,
It's very.
It's a real thing, so we want to make sure that we get the right antibiotic the first time. And then, if we do get our culture and sensitivity back and we have to change, it's like, okay, now I have a very educated change that I can make. I'm not guessing again. And, now I've created a super bug that's, I've tried 3 different antibiotics and now I'm resistant to all of them. And, we can induce colitis and we can induce bad things with too many antibiotics. So the culture and sensitivity is huge.
And I think the other thing to look at too is the most expensive medication is the one that doesn't work.
Correct. Yeah.
If it doesn't work, you just wasted it.
Yeah.
You wasted time, you wasted money. Let's go get the right ones. Let's narrow this focus down as much as we can. Let's get as close to correct. Let's save time and money.
Yeah.
And move forward.
Yeah.
So.
Absolutely. So then once we have our answer and we know what kind of path we need to go down, we can talk about managing these guys.
Management's everything.
Yeah.
Owners got the hard part.
Yeah, they do.
What does management look like? What are we focusing on here?
Yeah, so basically, like I said, when I'm getting my history, I'm figuring out what scenario is that horse's clinical signs the worst in, and I'm going to avoid that scenario at all costs.
Right.
So if they're in the barn and they're coughing, turn them out. If they're a summer pasture associated and they're worse out on the pasture in the dry parts of the summer, bring them in, put them under a fan. But basically the biggest thing is decreasing dust and decreasing the allergen. So we're just trying to decrease the organic debris that is aerosolized or floating around in the air that these horses are breathing in and reacting to. So it looks a whole lot like pelletized feed that you're wetting down. You can wet down your hay. Some people get the hay steamers. They steam their hay.
I will tell you, the hay steamer,
it's
game changer on these horses.
Yeah.
Back when we were just soaking, I would get fairly decent response. With the hay steamers, I know they're pricey, but I've got horses that they're having problems with that dusty hay that we have medication free. And that's our whole goal.
Yeah.
Because as we're going to talk about, medication, it gets us over the hump, but we're not changing the disease process.
No.
And the management's what changes the disease process.
Correct. Yeah.
My big thing is telling people, like, it's all about ventilation and paying attention.
Yeah.
Where you feed. A lot of people want to feed down on the ground. I encourage everybody, walk into your stall one day and just sit down and as your horse is kind of walking, and be careful, but as your horse is walking around the stall, if you've got light coming in through that window, you can actually see where that dust is. A lot of dust down there by the floor, which makes sense because you got shavings.
Yeah.
And the further up we get, a lot of times we can minimize that dust.
Yeah.
Good circulation, where you position them in the barn, I think is important.
It is. Yeah. That is, and then just being like cognizant of, is that horse in while you're blowing out the aisleway, sweeping out the aisleway, cleaning stalls? Like if you can turn them out into a paddock while you are doing your barn cleaning and your barn management for the day, that's huge. Just trying to decrease their exposure as much as possible. And then my biggest thing that I deal with a lot is people feeding on round bales with these horses. This is a like, do not pass go, do not collect $200, like do not do the round bale thing with asthmatic horses. It is,
your round bale days are over.
Yeah, it is not something that we can do.
You watch horses eat on a round bale and they tunnel into this thing.
Yeah, they've just got their noses buried in it and they're just breathing in dust and allergens and you're like, oh no.
And I always encourage people, like, take time, go out there, put your face in that hole, take some breaths. You start sneezing, you don't want to be there. I agree with you 100%. Round bales, asthmatic horses.
It's a no-go.
That's a no-go.
Yeah.
That's a no-go.
Yeah. I have people in school, when we had asthmatic horses or respiratory horses come in, we would bed them on cardboard shavings. It is like no dust and it's fabulous. It is not the best thing as far as like bedding goes, as far as like absorbency and cleanliness, but it is very minimal dust, which is nice. But you can mist down your shavings to decrease some dust. Make sure your arena is really well
avoid straw bedding, avoid. And remember, it's not just that horse, but his neighbors unfortunately get new bedding too.
Yes. Yeah.
So it doesn't have to be the whole barn, but horses in his general vicinity, you need to think about changing that bedding as well.
Yeah, absolutely.
I love the pelletized bedding on these horses.
The pellets are good, yeah.
Again, not the greatest. It's not as good as a shaving. And if you are going to do shavings, this is where you got to look at big chips. Around here we've got the poultry industry. We get most of our barns getting shavings in bulk. Pay attention how dusty they are. Depending on what they're grinding, it can be an issue. And then also pay attention to your shavings when you're getting them in bulk. Are they pure pine, or is this mill working some hardwood in there too? Because those hardwoods are way more allergy causing than the actual pines. No different. Most people aren't allergic to pine pollen. Pine pollen is so incredibly large, it's hard to get deeper into the airway. It's that hardwood pollens. That's what most people and most horses react to. So it's a good idea in general to avoid hardwood shavings, but make sure if you're buying in bulk, you're making sure you're not grinding hardwood into that as well.
Yep.
So.
And then, like I said, just paying attention and figuring out what those horses' triggers are and just avoiding them every time you can.
I see a lot of the summer pasture associated. It seems like the early mornings dews on the ground, especially in this area. We've got a lot of fescue. That's been implicated. It's growing that endophyte, which that endophyte in itself, that fungus, can be a trigger for asthma. And so a lot of those horses, we love night turnout in the summertime, but we've either got to get up in the mornings before that fungal bloom starts and get those horses in, or we've got to turn them out later in the day a lot of times once the moisture's off the grass, those horses seem to do better. But luckily I don't see that one near as much as I do the environmentals, the dusty barns, the dusty hays, dusty rings. Those are where I see it the most.
So like we said, that's the biggest part of managing these cases is managing the environment. When we step in with, we give you prescriptions and we help you with the medications and everything, like that's a minimal part. And that's, like Dan said, is not changing the disease process. That's just basically slapping a Band-Aid on it and managing the symptoms until we can change the environment and decrease those triggers. So the way that we treat these guys is basically with two different medications, so steroids and bronchodilators. So your steroids are here to decrease inflammation and help kind of dry up as much as we can, and then your bronchodilators are there to open the airway. They are exactly like people with rescue inhalers. They open airways and they help to just alleviate that feeling of breathing through a straw.
The severe cases, you've got to have those systemics on board, but one of the things, systemic steroids long term are not a great plan.
No.
Which is, I'm really thankful we've got. Lord, this podcast is making me feel old because I can remember we didn't have these things. I don't think it was that long ago.
And I'm over here spoiled, like I've never been without them. It's
I've
great.
always had a FlexiNeb.
Yeah, it's fine.
The FlexiNeb inhalers,
fabulous.
That has been a game change.
Yeah.
We used to try to use the human inhalers with this thing you stick up their nose. The horses absolutely hated it. The FlexiNeb actually allows us to actually get multiple different medications directly to where they need to be.
Yeah. In a small particle size that's aerosolized, and
and reduce the systemic effect of the steroids.
Yeah.
So, big FlexiNeb fan. Love it. Severe cases, a lot of times we're starting on the systemic, switching them over to that inhaled steroid.
Yeah.
Also that inhaled bronchodilator, some mast cell stabilizers, things like that.
Yeah.
We got some great meds that go through that, and like I said, if you hear us say asthma, go ahead and start planning in your mind FlexiNeb. And a lot of people I think get nervous because they see the price tag of that FlexiNeb. But I promise you, yes, it's a lot up front, but the medication is so much less expensive. This thing will pay for itself.
Oh, yeah.
It will pay for itself.
And you can use it for more than just asthma. Like, you can use it for, horses that, if you do have a pneumonia case, like you can nebulize antibiotics to them. You can help with, I've had babies and things that I've had to nebulize, and you can use it for more than just asthma. You can use it for more than just one horse. Like it will pay for itself inevitably.
Absolutely.
Yeah.
The one thing I tell people when you get one, again, your horse is breathing through this thing. Cleanliness is everything.
Yes,
Clean.
Yeah.
And it seems odd that we're going to put this thing that looks like a bucket. These FlexiNebs, it seems like they're going to freak out when you put them on it, but I've never had one do it. Most of my people put them on,
I've had lots of horses relax, honestly, when you put it on, because they're like, oh my gosh, thank you.
Yeah.
It's just like a breathing treatment for people is basically what we're doing. And it does help a ton. I run into a lot of cases where having them on systemic steroids is a risk because they are also fat, or they're cushingoid, or are insulin resistant. Like, you have all these comorbidities, and I'm like, gosh, it needs steroids because it has to be able to breathe, but I want to be able to pull them off the systemics as fast as I can.
Well, another thing that really helps is moisturizing those lungs. We talk about those Kirschman spirals.
Yeah.
Getting moisture in those lungs helps get some of that excess mucus out, helps get some of these Kirschman spirals out. The more of that stuff we can clean out of the lungs, if those lungs stay occluded for long enough with that mucus, they're going to start to consolidate. When those lungs do start to consolidate, that's lung we're not getting back.
Yeah.
So I think that's the other benefit of the nebulizers, is we can get that out.
Yeah.
You know, I've seen a lot of makeshift things that people have made. They work, but in all honesty, you've got an asthmatic horse. You're in for the long haul.
Yeah.
Make the investment, get the flexi neb, and let's get on with treatment.
Yeah.
Systemic bronchodilators, big one, clenbuterol.
Yep.
One of the things to remember, there's different buterols, right? And again, the most expensive medications that doesn't work.
Correct.
Albuterol has like 0 oral bioavailability. If it's not inhaled, it's not going to work.
Right.
Albuterol syrup is really cheap.
Yeah.
I joke, if you're going to use albuterol syrup, put it on their back. That way you're not having to fight to get them in them. It's going to work the exact same
as if you did.
As if you got in orally. You're going to need the clenbuterol.
Yeah.
Clenbuterol, we know it's orally. We know it's bioavailable orally.
We know it works.
It's going to work. Great medication. And a lot of times I've got some of these horses we're managing with the nebulizer that need a little bit of a bump, and I don't have to go to the systemics. I can have them on the inhaled steroids, inhaled bronchodilators. I can give them that short course of the clenbuterol and get these horses over that hump and not have to grab that systemic steroid as much.
Yeah. Yeah, because it's not benign, and we wanna get them off those systemics as fast as we can, and the nebulizer really allows us to do that. But yeah, it's a disease that, you know, you are in it for the long haul, and trying to manage it with fewer systemics, I think, is gonna be more cost effective in the long run.
Yes.
So.
Well, and I think looking at that too, one of the things I do like to tell people is, you focus on these two things. You focus on management, because again, my population, a lot of performance horses. If I've got the owners focused on the management, we figure out how to control these horses with medication. They can still go on to do what they need to do.
Oh yeah.
Catching it early. I try to say, if we catch it early.
Yeah.
The owners are doing their work as far as the environmental management. We're doing our work, getting the right medications at the right time. These horses can go on to be perfectly usable, perfectly normal.
Absolutely.
And we can have a good outcome, and we can really slow this progression. And that's the whole key. We got to slow this progression.
Yeah.
And they can have a really normal life, but it does take, like, it's no different than people that are asthmatic. This is who we are. This is what we're living with. And we're going to be okay, but we've got to do these things. Yeah,
and you're going to have setbacks and episodes because it's an episodic type of disease, and you're always going to have a little bit of progression. But if we can stay on top of it, we can minimize that as much as possible, and then they can have longevity, and they can have normal careers.
And a lot of times, changes in environments. That's one of the things I find. My horses are doing great at home.
Yeah.
We're going to load up. We're going to ship to Florida. We're going down to Florida for the winter.
Yeah.
We're going to leave up here in January. We get to Florida, and it's almost like springtime here. And it's going to set this whole cascade off. So we go ahead and we have everything written up, like, okay, this is what we're doing. This is how we manage. And I think that's another important part, too. When you're dealing with show horses, we've got drug rules we got to be within.
Yeah.
USF's big on that. We need to hit these drug rules. We can do that. Using the flexi nebs, we can manage through this, keep you show legal, where you're not going to pop a test.
Yeah.
And still be able to use your horse. But
yeah,
I think navigating that, I always say the first year is the toughest. The first year is always the toughest. You can get past that first year, life's pretty good.
Yeah. Yeah, I had one haul down from North Georgia up in the mountains, and she came down here, and it was middle of like just hot and dry and miserable. And that horse, I got there, and I was like, "Oh, you poor thing," and she did. She got a FlexiNeb, and she is doing great, and she can basically go wherever she wants now, and she's got a plan, and she knows what the triggers are, and so she just goes and does her thing.
Yeah, it's really, like I said, it sounds terrible, but at the same time, very well managed.
Yeah.
If you do all the things right, it really easy to manage.
Yeah.
So we're coming here to the end. Let's get a quick summary in here. Things to watch for.
Yep. So you're going to watch for coughing. You're going to watch for decreased performance and increased abdominal rate or respiratory rate and effort. And then, paying attention to dust, really harping on that management is huge. And then just being proactive. Like we always say, if you can be proactive and you can catch it early and manage it, then you're in a much better spot.
Yeah, call the vet, get us out,
Yep.
get that accurate diagnosis. Cannot encourage that enough, because if without that accurate diagnosis, all those little details, is there straight asthma? Do we have subclinical respiratory infection? Knowing exactly what we're dealing with is huge. It's going to be a big workup on the beginning side, but once we get that stuff, once we got that plan in place, it's pretty smooth sailing.
Yeah.
As long as everybody does their part.
Yep.
So, all right. Well, Dr. Caitlyn, thanks for being on today.
Absolutely.
I hope y'all enjoyed that. If y'all have got questions, send them in to us. You can DM us. Again, I'm still learning about all this, but DM us, send us an email, shoot us a call, whatever we can do to help. If y'all have got things and topics that you want to cover, please let us know.
Yep.
So with that, thanks for tuning in, and we'll see y'all next week. Thanks.